Welcome. We are so delighted to have all of you here with us today as we are celebrating our annual research day and our Bullough lecture day. And it's hopefully the sun's going to come out in just a little while to make it just a little brighter and sunnier. So I want to thank all of you for making the trip to come here to University at Buffalo. It's a great opportunity for all of us to share research and some of the data that our community partners and our students and faculty have generated that can help inform our practice and help make us better at what we do as clinicians, as scientists, and people that are out in the community trying to talk about all of this work, which I feel like is what I do. I get to be the proud grandmother to brag about everyone's accomplishments. And so I always like to point to all of the things I learn when I come to these events and make me rethink too many things that I might have learned years ago that were what I would call perhaps sacred cows. And sometimes those sacred cows don't really have a fundamental basis in the facts or in data that's collected. So it's always good to have an opportunity to come to research days especially when they're close and we can learn more from each other. I want to share with you, as many of you know, we are preparing for Nurses Week this week. And many of you I know are also, as I am, a member of the Professional Nurses Association of Western New York. And Linda Scharf, who's the executive director of that group, sent and provided for me today a proclamation from our county executives to celebrate National Nurses Week. And I'd like to share some of that with you. And this is all those whereases, but whereas the Professional Nurses Association of Western New York is dedicated to promoting excellence in nursing practice, improving the quality of healthcare services, and encouraging the professional and leadership development of registered nurses. And whereas the Professional Nurses Association of Western New York is the voice of registered nurses in Erie County, and whereas there are 16,000 registered nurses, 1,700 nurse practitioners in Erie County, 400 registered nurses, and 30,000 nurse practitioners in New York State, and more than 5.2 million registered nurses and 385,000 nurse practitioners nationally. Whereas since the beginning of COVID-19 pandemic, Erie County and New York registered nurses have been on the front lines protecting and caring for their patients with the utmost dignity and respect, demonstrating unprecedented courage during such an uncertain time. And whereas professional nursing has demonstrated to be an indispensable component of the safety and quality of care of hospitalized patients, whereas National Nurses Week is celebrated May 6th to the 12th, the Professional Nurses Association of Western New York has identified the theme, Nurses Make the Difference in Western New York, and will celebrate the ways that registered nurses advocate for high-quality patient care, and whereas the P&A of Western New York will embrace this theme, highlighting the need for supportive work environments, diversity, equity, and inclusion, therefore it be resolved that I, Mark Pollenkrantz, Erie County Executive, do proclaim May 6th to the 12th National Nurses Week in Erie County. So I wanted to share that with you today because I think it was a great summary of thinking about what we are here doing as professionals, as what we do in our research careers. So I welcome you, and now I'm going to turn the microphone over to Dr. Chang, who will introduce our Bullough lecture this year.
Thank you so much, Dean Wasaki, for the warm remarks. It is my great honor to introduce Dr. Lisa Thompson as the keynote speaker for the 28th Annual Bonnie Bullough Lecture. Dr. Thompson is a tenured professor at Emory University's Nell Hodgson Woodruff School of Nursing with a joint appointment in the Genza Rosa Department of Environmental Health at the Rollins School of Public Health. Her research focuses on air pollution, climate change, and implementation sciences, with a global commitment to improving women's health. Over the past 2 decades, Dr. Thompson has led groundbreaking work on household air pollution in Guatemala, including serving as a principal investigator for the multiple country household air pollution intervention network trial, which tested the impact of clean cooking interventions on maternal and child health outcomes. She currently leads Ecolectivos, I hope I'm saying it correctly, which is a village-level cluster randomized trial using participatory action research to reduce plastic waste burning in rural Guatemalan households. Through her work, Dr. Thompson addresses the intersection of environmental exposure, poverty, and health inequities, with a focus on developing sustainable, community-driven solutions. Dr. Thompson is a fellow of the American Academy of Nursing, a member of Emory's Network for Evaluation and Implementation Sciences, an affiliate of the Emory Climate Research Initiative. Before joining Emory, she served on the faculty at the University of California, San Francisco School of Nursing. In addition to her academic work, she has spent much of her career as a nurse practitioner providing care to underserved communities, including undocumented and uninsured populations in East Oakland, California. So please join me in welcoming Dr. Thompson.
Okay, let's see. Can you hear me? I think you can, right? All right. Yes? Okay, thank you very much. I'm going to just see if I turn this computer on here, where I have a few little notes just to help me with some of the slides. And then I'm going to see if this works, which it does. All right. And this is a nice big screen. I might be able to get away without these glasses. So you've all had a long time to glance at my slide, which introduces my title. I'm so happy to be here today giving this lecture. And I note that Bonnie Bullough was also the first, the founding director of the nurse practitioner program in California in 1968. So not only was she a visionary dean at your school, but she also founded the first nurse practitioner program in California. These are my acknowledgments and disclosures. And I thought I'd just start off with a little bit of my background, although Dr. Chang did tell you a little bit about me. I wanted to show you how nobody's career path is linear, but it always ends up, even though circuitous, to end up in some way representing where we all are today. So never linear, always circuitous, but it stands to reason that we're ending up where we should be, even though we don't know it at the time. So I started off with my bachelor's in Latin American studies from Tulane University. I thought I'd be an anthropologist, so I ended up studying anthropology at La Católica in Lima, Peru, for about a year and a half. For reasons, life circumstances, I ended up out in the California in the Bay Area and decided I wanted to be a nurse, basically because you can't support yourself as with the Latin American studies and anthropology half degree, and nursing seemed like a really practical thing to do. And I went to nursing school and I loved it. So I got my bachelor's degree in nursing and then my FNP degree and worked for about 15 years as a family nurse practitioner in La Clínica de la Raza. Loved working with Latino kids and thought that I would apply to graduate school to study the problem that I saw frequently in my clinic, which was Latino kids with asthma and environmental influences. So I applied to UC Berkeley because I lived in Berkeley and got into the program to study environmental health sciences, where I got my master's and my PhD. Then I was lucky enough to cross the bay and become an assistant professor at UC San Francisco. So I want to give you a little bit of background on household air pollution because it's something that we all think about the air pollution here outside, sometimes on a smoggy day. But this is a smoggy day in Delhi, in India. And you probably can't see it because there's a little light in here. But there are cars on the street. And this is daytime in Delhi. This is air pollution, about 155 out of 365 days a year. This is what it's like to breathe this air in Delhi. This is the kind of air that causes you to, have a hacking cough, a sore throat, itchy eyes, runny nose. And this is what people are breathing Not only does it cause acute symptoms, but chronic symptoms, of course, cancer, lung disease. Combined with what people are breathing indoors from cooking fires, this is a dual burden that represents the single largest environmental risk factor for ill health. So I think a lot of us understand that, diarrhea is a common killer for children around the world, but I don't know that a lot of us think that air pollution actually is the largest single environmental risk factor globally, and it is. This decision about what type of stove or fuel to use right here, this is a stove, this is what women are cooking with. It's a three-stone fire, is something that is not made by a woman herself. It's a family decision. And so this becomes a gender issue, okay? Because poverty leads people to what am I going to cook with? If I have to choose between a stove versus putting my children in school versus buying shoes versus many other decisions households have to make, the stove might be the last decision that people make. So if we have a decision to measure, to intervene upon a stove, that may be something that is not just something that's as simple as saying, why don't you have a clean stove? It's a decision that's a household matter. And in fact, over a little under half of the world cooks with these types of stoves. They could be cooking with wood, coal, crop residue, even animal dung. And 2.1 billion people around the world rely on these polluting fuels. Thus, it leads to the 9th leading cause of death globally. And this is a picture that I took when I was a master's student. My first air monitoring study that you can see maybe a little red basket up at the top with a monitor in it, and at the bottom is a three-stone fire. This kitchen has 240 times the level of air pollution that is the standard according to the World Health Organization. At this point, I was standing outside the kitchen, my eyes are watering, I couldn't go in there. And this is what women are experiencing on a daily basis, 3 times a day. So this is not just an experience that women have, but also their children and elderly women, because children are on their mother's backs or near their moms when they're small, and elderly women like to be, or elderly people, men and women, like to be in these kitchens if it's cold to be warm. In warmer climates, these stoves sometimes are outdoors, but in colder climates, these stoves are also used for heating. So what is the result of this? Over 3.2 million people globally a year die prematurely from this exposure from household air pollution. And it's from these stoves, but also from kerosene stoves, which is a liquid stove, but it's also very polluting. And what are the attributed diseases that are stroke? 23% of these diseases are attributed to stroke, 32% to ischemic heart disease, 19% to chronic obstructive pulmonary disease, 6% to lung cancer, mostly from smoky coal, and 21% are due to lower respiratory infections in children. So now I'm going to tell you about the solutions, okay? So what do we do with this? Well, I was involved in 2 trials, and I'm going to just briefly go over the results from these 2 trials. So the first one is called the Respire trial, and this is the trial that I was involved in when I was a student at UC Berkeley. So I thought I was going to go in and be lucky enough to be involved in a study in Oakland, where I lived, and I'm going to work with Latino children and that are exposed to air pollution outdoors and asthma. And I get this call from Kirk Smith, who turned out to be my advisor, who said, I've got a study in Guatemala with these stoves, and people cook over these three-stone fires. And I'm like, I don't know this problem. I've never seen this problem. And at this point, I have to ask anybody here been in a country or experienced this type of cooking conditions? Just raise your hand. There's always some people who have been in a place where they've seen people cooking over these stoves. And so I had not. But now I've spent about the last 22 years sitting in kitchens, seeing people cook using these types of stoves. So this trial, the Respire trial, was conducted between 2002 and 2005 in rural Guatemala. And we randomized over 500 households to receive the wood chimney stove like you see on the right. This is a locally produced stove. This is very well, people wanted this stove, and they knew it was called the plancha stove. And we randomized the women to receive this stove either in the beginning of the trial, when the baby was either less than 3 months old, or the woman was pregnant, or they received the stove at the end of the trial when the baby reached 18 months of age. Okay, so we had this randomized stove trial, which is the first trial ever. So it's pretty foundational. This chimney reduced children's exposure by 50%. So we were able to drastically move the smoke from inside the house to outside the house. So what were the results? This study, which was one of my dissertation chapters, was the first study to measure birth weight in a randomized stove intervention trial. And we were able to measure only 190 birth weights at less than 48 hours of birth, because not all women were pregnant in the study. And we also had to go to the homes, measure the babies at home, because they were delivered at home by traditional birth attendants. So this is very challenging. The low birth weight was so high, it was 22.4%. So these were these babies were very vulnerable to begin with. And we found that the babies born in the households with chimney stoves weighed 89 grams more than the babies born in the households with open fire. So we saw an effect of the stove, which was clinically significant. But due to the small sample size, it was not statistically significant, because you can see the odds ratio of a protective effect, but the confidence interval crosses 1, so it was not statistically significant. We also did a study that was published in Lancet looking at pneumonia. That was our primary outcome. And you can see here that among 265 intervention children, we had 149 doctor-diagnosed cases of pneumonia, which is really high. So over half of the children had pneumonia in this study. This is back in 2002. So there were less vaccines at that time, right? And these kids were already, like I said, very vulnerable to disease. And then among the control children, we had 180 cases of pneumonia. And the rate ratio here shows that there was a protective effect of the chimney stove, but the p-value was 0.095, not statistically significant, but almost getting there. We did show a 22% reduction in pneumonia, again, not statistically significant. So at this point, it's December of 2000, and I can't even remember when, the results came out, and the PI of the study, Kirk Smith, was pretty depressed because the study showed this effect, and we had spent a lot of time and effort to measure this effect, and this was the result after a lot of effort to really carry out this rigorous trial. But it was almost there, on the cusp, but not quite. And this is a study that was just published recently in 2024 on this trial, where we followed up on the children to look at stunting and the effect of air pollution on stunting. We measured these same children. We added a few children in the follow-up cohort, and we followed them to 5 years of age. And these are Hmong indigenous children in Guatemala. The stunting is tremendous. Over 90% of the children were stunted according to WHO standards. They're very small children. And we saw an effect of the increased carbon monoxide that's produced from the stove on stunting, and this effect was stronger in boys. Okay? And so with 1 parts per million increase in carbon monoxide, for every 1 part per million increase in carbon monoxide, we saw a 0.21 decrease in the height for age Z-score, which was statistically significant and clinically significant if you look at height for age Z-scores. I do want to point out that this paper was published 15 years after the data was collected. So I do, for those of you that are hanging on to old data, don't give up, because this paper was published. So don't put it in the closet. Pull it out. So now I want to move to the next trial, because I said there's a tale of 2 trials. So with the Respire trial that used a chimney stove, where we let people keep cooking with wood, but we gave them a plancha stove that used wood, but it had a chimney to move the smoke outdoors. we realized that we reduced exposure by 50% with a wood stove, okay? But the stove wasn't clean enough. It basically moved the smoke outdoors. And if you live next door, that smoke's coming indoors. So we needed to get a cleaner stove. So with a lot of effort and multiple investigators and a lot of push to move the next trial into the funding stream, we convinced National Institute of Health and the Bill and Melinda Gates Foundation to fund the HAPIN trial, which stands for Household Air Pollution and Health, Multi-Country Liquefied Petroleum Gas Intervention Trial. And this was funded in 2016. And it's a randomized controlled field trial with a liquefied petroleum gas stove trial. So in the United States, I think we all have seen studies that say gas stoves are not as good as electric stoves. And there's some problems we've seen in the literature where people say electric is better than gas because electric can cause some problems if we cook indoors, and we should use vents in our houses to get the gas outside. I don't know if anybody of you seen those studies, but in these settings, gas is always cleaner than wood stoves, okay? And people in these settings don't have reliable sources of electricity, so gas is the only option. That's the cleanest option for people in these settings. So with this justification, we wanted to set out to provide this LPG stove. And this was a huge trial. 3,200 households were randomized in 4 countries, Guatemala, India, Rwanda, and Peru, because we wanted generalizable results. Not just one country like Guatemala, 4 countries. And we provided this type of a stove. This is the Guatemalan stove, and all the free fuel you want. You're never going to run out of fuel. If your tank gets low, we're going to come out and deliver fuel. And this intervention was started in the 2nd trimester of pregnancy. As early as they got pregnant, we would give you the stove because we didn't want to have we wanted the early trimester effects as early as we could. And then we looked again at some of the same outcomes as Respire. Because if Respire didn't find an effect, we thought, well, maybe it was because the stove wasn't clean enough. So what happened? And I was not a PI on this study. I was a co-investigator. There were 50 investigators on the study, and I was the only nurse. I was also the only nurse on Respire. Well, in order to get this study, I wanted to say that in Respire, we gave people a stove that they liked and knew how to use. If you give people a gas stove and they've never known how to turn on a knob, how to regulate a flame, how to cook with a new technology, we need behavior here. This is a brand new technology. And I can tell you that one time we observed somebody cooking tortillas, and then they're like done, and they walk away and they forgot to turn off the stove, because what happens with the wood stove? It dies down. And we're like, wait, you just left the gas on. And they're like, well, it'll die down. It'll go out. And we're like, no, you got to turn it off. So this is all behavior. So these are 3 papers that we did. One of them is an earlier paper from a study that I did, where we worked on behavior change communication. How do we model behavior change so that people can actually understand how to work with a new technology? So what are the results? 3 of these papers were published in the New England Journal of Medicine. The first looked at, and I want to say that the stove reduced exposure incredibly. I mean, it was a very successful stove, and we've got other papers on that I won't go into. It reduced it from low to super low, okay? 3,060 live infant births weighed less than 24 hours in hospitals. And you can see the birth weights of these in the intervention and control is essentially no difference, 19 grams. The confidence interval, no difference, not statistically or clinically difference. Nothing. Pneumonia, severe pneumonia. 175 episodes of severe pneumonia in over 3,000 kids. Very low rates of pneumonia compared to Respire. The cases per 100 child years in both was essentially the same, very low number of cases. The rate ratio with the p-value of 0.81, absolutely no statistically significant differences, even though we had reductions in air pollution. The final one was stunting. And this, we had high rates of stunting in both groups, 27 and 25%, but there was more stunting in the intervention group. And the relative risk was p of 0.12, right? But it was in the direction of the intervention group being more stunted. So you can bet these were very, very disappointing results. And since it was such a large trial, it caused a lot of discussion, because a trial like this will not be done again. And so for the community of household air pollution researchers, it's kind of like, uh-oh. So that led us to think we have two major randomized intervention trials. There's others that I have not discussed, but because I wasn't part of them, but I know about them, that have kind of found some similar results, some on borderline, some are successful, but most of them have shown similar results. And some have shown suggestion of effects, but what do we do next? If you look at observational studies, there's always an effect. Trials don't show an effect. Trials are supposed to be the bread and butter of causation. So we got a large team of people together who've been on many trials, and we had a consensus document looking at different interventions. And this was published in the American Thoracic Society and recently. And our basic recommendations were that we need to address energy poverty and clean cooking solutions. In other words, we can't say trials didn't work, keep cooking over polluted stoves, right? I mean, people need clean cooking energy. So you're not going to say, keep doing what you're doing, because it's obviously not a good thing. People do not want to cook over these types of stoves, but we just couldn't say it reduces pneumonia, it improves birth weight, because that evidence is not there as of yet. All right, so moving on, what happened to me as a result of that? I'm not doing those trials anymore. I noticed something else when I was there. I noticed that people were burning plastic in their fires. On the left, those are crocks and a big Coke bottle in an outdoor fire. And on the indoors, that's a big piece of Tupperware and green plastic. That's inside of the stove, the cooking stove. So I thought, what is going on with all this waste burning? And why are they burning waste? And who is evaluating this type of waste? There are many studies where they look at people burning roadside waste. So if you go to places like I've been in India and parts of Africa and parts of Latin America, there's a lot of roadside waste and people are burning piles of waste on the side of the road. But this is indoors in people's homes. And I thought, what's going on here? Why are they doing this to get rid of it? Are they doing it for fuel? And so I kind of put that together and I said, this is what I want to study. But I didn't want to do it with the trial. I wanted to use implementation science because I felt like the trials, basically, you randomize into two trials and you go effect or no effect, and then you publish, and I wanted to do something about it. So that's why I wanted to use implementation science. So what is implementation science? I'm going to go through just a few things. I know how many people use implementation science as a research method. Okay, I've got a few hands up, so I'm going to go through it kind of quickly. This is the scientific method, okay, where you promote a systematic uptake of research findings and other evidence-based practice into routine practice to improve quality and effectiveness of health services. Okay, so something works, you know it works, and you want everybody to do it. Okay, and to make dissemination implementation science work, you need to understand the context. Otherwise, it's not going to work. You're going to put something into place in a place where you don't understand the context, it will fail. And to do that, you need to know what the barriers and facilitators are to effectively implement something. And you have to know, if you implement something right in one little space, you want to scale it up, because we just don't want to do something in this little space and this little space and this little space. It's a scale up. We want to take it out there into the wide world. That's the point of dissemination. Another thing, point 3, is we want people to de-implement ineffective or harmful practices. We always talk about implementing good stuff. We got to de-implement bad stuff, right? So my project is really de-implementing bad stuff, which is burning plastic. Okay, so that's more of a challenge. So this is one slide from a paper that's 1 page by Curran that discusses the definitions of implementation science in 1 slide, which is great. And basically, the intervention practice or the innovation is the thing. What's the thing that you're giving people? It's a thing. It could be a policy, a practice, a plan, a tool, an education, curriculum, all right? And then if you're doing effectiveness research, you're actually giving them something and you're seeing if that thing works in that setting, okay? But if you're doing implementation research, you're looking at how people do that thing in that setting, like maybe with re-aim. How well do they do that thing in that setting, okay? And then the implementation strategies are what's the stuff we do to get them to do that, okay? So that might be, I'm giving them education, curriculum, training, skills. These are the strategies to get them to do that thing I want them to do. All right. And then the implementation outcomes is more the measuring of how much and how well they do that thing. So again, that might be where we're actually counting, assessing through re-aim actual like proportions and numbers and counts of things, right? So these are all, you'll hear a lot of time, well, what are your implementation strategies? What are your implementation outcomes? Are you doing efficacy research, effectiveness research? You're doing implementation research. These all have different meanings. And this is a cascade which basically goes through some of that, right? So first, and I just want to focus on the fact that efficacy studies are like the RCTs, the randomized control trials. Effectiveness studies in green are where you take it out into the community and you see if it works in the real world. So the efficacy studies, the RCTs, are those tight controlled conditions where everything is kind of artificially set. And then effectiveness studies are where you let it kind of go out into the world and vary a little bit, see if it still works. And then up at the top is the dissemination implementation studies where you see how it works. How does it really work in that setting? You explore, you adopt, you implement, and you sustain. That's where you figure out how to get it into the wider world. Okay, scale it up, disseminate it, make that program work. So implementation science ran into it's a relatively new science, so they're still kind of trying to figure themselves out. And one thing that they said is we need more theories, models, and frameworks, which I think nurses understand, right? I mean, we're trained very well in theories, models, and frameworks. In my environmental sciences PhD, 0 theories, models, and frameworks, nothing. If I had not had a master's in nursing, I would have been like resistant to all of this. But when implementation science, when I had my training in this, I was like, oh yeah, okay, I like this stuff. So this paper by Nielsen organized the theories and models and frameworks into these buckets to try to help implementation scientists understand how you would use these. So they divided it up into process models, which helps guide implementation process. And then they have in the middle, they have the determinant frameworks, classic theories, and implementation theories. And then on the far side, they have the evaluation framework. So you could think of like on the far left, it's how you start a program. On the far right, it's how you evaluate the program. In the middle is kind of those fuzzy theories of determination, okay? So I put in here on the bottom TDF, COM-B, and re-aim because that's what I use in my trial. And I'll discuss COM-B. What's COM-B? How many people use the COM-B or the behavior change wheel or have heard of it? How many have heard of the behavior change wheel? I'm seeing a few hands going up. Okay, good. So in the behavior intervention design, first thing is kind of like a SMART objective. You have to define your behavior precisely. You need to know who is going to do the behavior, how, what, when, and where, right? It's precisely what is the behavior you want to change. So, in the behavior change wheel, the example is nurses hand washing in a hospital. Like you have to think precisely, where's the station, where's the soap, where's the nurse, how's she going to do it? Like it's very, very specific. And then you have to recognize that behaviors are part of a system, like it's a unit. It's, and there's many other people acting in this unit besides that hand washing behavior of the nurse. And then you have to figure out what the behavioral diagnosis is. How is she going to get over there to wash the hands and what's going on in the context? And then you have to think about what are the interventions that can target many levels and allow that nurse to get to the hand washing station. So the behavior change wheel is a framework for designing interventions. And Susan Mickey designed this guidebook, which is really a workbook that you can work through. And there are 4 rings, and I'm going to go through the green, yellow, and red ring. The outer gray ring is the policy ring, which I don't use, so I'm not going to talk about it. But there's some links to the websites here. They have great workshops and training programs, and it's a great resource. So the inner ring, the green ring, is the COM-B system, and there are 3 things that you have to influence in order to change behavior. You need to influence capabilities, which includes psychological or physical capabilities. You have to influence opportunities. Those are physical and social environments. And you have to influence, and those 2 things will influence motivation. And motivation is reflective and automatic. Really when the COM-B was developed, Mickey said it's all about motivation. You gotta hit motivation. And then they were like, well, but there's capabilities and opportunities. You gotta have those things too, right? So then they kind of brought those things into play too. So a lot of people in our field go, well, let's just educate them. Let's just train them. Let's give them an education program. And I see that all the time. Let's just tell them what they gotta do. They're not gonna do anything unless they're motivated, right? And so one of the key things is like, you can tell somebody that there were 23,000 people who died from drunk driving last year. They were hit by drunk drivers, right, or in accidents. But the most effective tool may be the Mothers Against Drunk Driving showing like posters of crashed cars. And that elicits a motivation of fear or like anger or whatever emotion elicits, which is a motivation. So they educate you with a fact. Well, that's not the same as a motivation, right? So maybe you need the capability, which is, to understand, that's a skill, but you need the motivation, which may be fear or something else to actually change your behavior. So those are the 3 things in the green inner ring. And then this yellow ring is very complex. And I'm not going to go into this much beyond saying that the theoretical domains framework are 14 domains that collapse onto the COM-B. And within those 14 domains, there are 84 constructs that are drawn from a ton of theories that experts sat around and did a systematic review and decided that, for instance, if you want to intervene on beliefs about capabilities in that domain, you may choose these constructs: self-efficacy, self-esteem, empowerment, etc. So it's very granular. And I've used this when I'm designing an intervention to think about what things I want to intervene upon. So in our trial, we're intervening upon empowerment and some things about social environment and things like that. You're not going to intervene on all of these domains. You have to kind of think it through when you're designing your behavioral intervention. You can use this as a tool to design an intervention. You can use this tool to evaluate an intervention. So in our systematic review that we're doing, we're also reading through the literature to see what people did in their behavioral interventions and extracting from this tool. So it's pretty useful. The red ring is the outer ring, and that's okay. What are we going to do? What's our intervention functions? What are the things we're going to do now that we want to change behavior? So for instance, you could coerce people, you could incentivize people, you could educate people. These are all the different types of intervention functions you can use. So read more about it because it's a very handy tool, and I don't think it is really that complicated. Is it, Daniel? Okay. Before I start talking about my trial, and I've just got about 10 minutes, I'm going to go through it really quick because I got a lot of nice slides. Everything I do is based in health equity, and I think that is very important for us as nurse researchers. It's the guiding framework for building community-level resilience and health promotion and implementation research. My trial is addressing a gap that addresses waste burning, which is absent. We use implementation strategies to reduce household level plastic burning. We're using an effectiveness implementation type 1 hybrid design. I'll tell you a little bit about that. We're working in 16 villages with 400 women. And our behavioral intervention is what we call working groups. And I'll describe that. And we're using the COM-B TDF framework and also re-aim to evaluate. It's an equity problem. This is the dump in Jalapa. This is all plastic trash. Plastic is made from petrochemicals. It's a growing problem. 2 billion people lack solid waste collection services. When it's burned, obviously, it creates a ton of pollutants, including carcinogens, phthalates, heavy metals. And this is a problem of poverty. The potential health impacts of plastic use. We hear a lot about microplastics here. So I don't think I need to, I don't think anybody here has not heard of microplastics. A lot of the problems, the health impacts are evolving and kind of hard to even discern because it's such a new science. Some of this comes from literature, toxicology in animals. So a lot of this is not like definitive, but suggestive. But obviously it's something that we don't want to expose pregnant women or children to. And precautionary principle, try to avoid exposure if you can, because we don't know what's a safe threshold, and we don't know what's permanent and what's not permanent. We just need to prevent exposure. So in our trial, we have 3 aims, and I'll walk you through them. The first aim is an implementation aim, which is a dynamic working group. Our second aim is our randomized control trial aim. And our third aim is a modeling aim where we're looking at emissions. So our study is also located in an indigenous group of people. They're Xinca. And just to give you context, this is a sign that says we're united against the struggle to protect our forests, water, and soil. We do not like mega projects. So they do not want mining programs coming in. They're pretty closed to outsiders. So in other words, they want to preserve their lands. And so we need permission from them to come in, which is great. They want us to work to help them protect their soils. This is a woman who showed us the way they used to cook and eat off of ceramic, and now they're eating off of plastic. So we work with stakeholders. We get permission from all the communities. We work with municipal officials, village champions, and our field workers come from these communities. We did a baseline assessment where we went to 1,500 households in these 37 villages, and we did a simple random sampling, 60 households in each of these villages to assess their capabilities, opportunities, and motivations. And we also identified the women for our main trial. And we found that 88% of the people burn household waste outside, 67% burn household waste in their cook stove, and only 5% have garbage trucks. They don't have garbage trucks coming to their homes. So they got to burn it or they dump it. And we used, I'm not going to go through all of this, but we used our information to map out their capabilities, opportunities, and motivations to try to create our working group curriculum. And this is it looks like a blob, like maybe a macrophage or something. I don't know what it looks like, but this is a map of our villages. Since it's cluster randomized, we paired the villages by size and density and location so that we have 8 groups of 2 villages each. To get permission, we have to go to each village and present our study, and then we do baseline exposures with the 400 women, 200 in the control and 200 intervention. So we, do our baseline assessments. We do a community diagnosis to understand what's going on in each village, and then we randomize. And so our first aim is our working groups, and that's where we do a 12-week working group, and mostly with women. And you can see here they're gathered around Chico, who is teaching them how to do worm composting. And this curriculum, which you can't read, shows every class and what we do in each class. But I will highlight some of the things that we do in each class. They're very dynamic, so we're always doing stuff. And we have them, they do homework. So they have to come back and turn in their homework or tell us what they did. And we do group activities. So we have a recycling day where they bring all their stuff in for recycling, and they get money. So a vendor comes in and buys from them. We have a community cleanup, which has been hugely successful. They make soap, organic soap, which is because they were using plastic bags of soap and dumping the plastic bags and burning them. And we do composting. The most popular thing has been community cleanups. And I should say these 12-week dynamic working groups, in the end, they choose one thing they want to do for 9 months. And we follow them for 9 months, and we provide all the resources for a full year. So we follow them for a year and help them to choose one thing they want to do. And most villages have chosen community cleanups. That's what they want to do for 1 year. And what has happened in this 1 year is they have put up signs in their villages that say, we're going to fine you if you throw garbage in our village, and you see cleaner villages. And for recycling, we've had an average of 25 people per village show up to recycle. They recycled about 520 pounds of plastic and PVC that they've made money off of, and a ton more of metal and glass and other stuff I didn't include in here. I just focused on the plastic. And for cleanup, about 1,700 people have participated in 37 cleanup campaigns, and they've gathered together over 4,000 large trash bags, which have been taken to the dump for recycling and processing. So it's like massive, massive efforts on parts of the communities. And the point of that is we're done after 12 months. They keep going because they get into this habit, and then the church takes over and the community takes over, and they just keep going and going and going. So it's like adopting a new behavior. We also have environmental health promoters, which we've trained, and they work with us, and they also work with the women in our program. So they go around and talk about burning plastic. They provide educational messages. And these are women that also will stay in the village after we're done. So we've trained 2 women per village kind of to keep the intervention going, which has been very successful. I think they feel a lot of empowerment from being a part of the project. And this is our biomonitoring aim, where we're collecting exposure measures. We measure urinary biomarkers and air pollution. I'm not going to go into this too much, but I just want to say we measure a lot of urinary biomarkers, a ton. We compared them to national, to NHANES data, which is from the United States. And everything that's in dark black on the left-hand side is statistically higher than what was measured in NHANES. So we've got a lot higher urinary biomarkers of exposure to plastic-based stuff. This was just from a small pilot, but they're more highly exposed than what we're seeing in a national representative sample in the United States. And this is a modeling aim, which we're actually taking these measures and trying to model the exposures at a regional level to tracers of plastic waste burning, which I don't have results for because we're still in the middle of the trial. It hasn't ended yet. The last thing I wanted to say is we are doing a reforesting program. One of the things that the community said to us is, what did the control villages get? I mean, the intervention villages are getting all of this like stuff, but what do we get? We just sit here and get monitored for, our urine and our air pollution. Like, that's not fair. And that's great. And so they said, well, you can give us trees. So we are giving these control villages, these 8 control villages, 3,000 tree saplings per village. So we've given them 27,000 trees, and they're really happy with them. The other thing that we're doing is in year 5, which starts June, if we get funded in year 5, we're ramping up to do intervention fairs, and we're going to go to these 8 control villages. We're taking our health promoters, and we're going to have a one-day fair where we give them everything that the intervention village got over 12 months in one day, which is going to be like a fair with a bunch of tables where we talk about recycling and composting and organic soaps and all that kind of stuff, recycling. And then we're going to give them the community cleanups for 3 sessions. And so that's another way to promote what we've done in intervention groups to the control groups. So just in summary, Ecolectivos is the first randomized controlled study to use a behavioral framework to implement an intervention to plastic waste burning globally. It's the first study globally to conduct a detailed personal exposure assessment on women. And our study aims to build a sustainable local strategy to find these groups to reduce air pollution that they can do on their own. And women say we're not burning plastic anymore. I mean, they just say it all the time. We're not burning plastic. We're not burning plastic. We're finding ways to get rid of it, but we're not burning it anymore. So we'll see whether that bears out when we actually analyze their data, because the study ends in 2026. We have a huge group of people. I've got investigators from several different universities, and most of all, the people from the university in Guatemala, which is on the right side. It's a huge team, and they're amazing, amazing, amazing people that I could not do anything without them. And Daniel knows, because he got the fortunate opportunity to get to know them. So thank you very much. And I really went fast, so I got done on time. I don't know if there's any questions. Yes.
Read this level of detail about the work and wonderful. And I guess it's sort of a Daniel with the question that had something like, does urinary metabolites the kidney damage?
The kidney damage? None of those actually, but we have creatinine. I guess we do have creatinine.
Okay, paper to write.
Yeah, because we do creatinine. All of these are creatinine adjusted. Never thought of that. Daniel, thanks, Maeve. We got 400 women measured 3 times over 1 year, and we have season. We might have heat.
Okay, let's do it.
Ambient air pollution monitors. Yeah. Yeah, and we definitely have seasonal heat there. Yep. Yes.
If you notice, there's not much difference from you standing up or sitting. If we're interested in diversity, I only point out to you that in worldwide, there's tall people and short people. And so when they measured the individuals from Guatemala, and they said they were stunted, did they, who do they compare them to? Worldwide height or their genetic variant?
This is a great question. Okay. Very good question. So this is a standard called the multi-reference growth standard. World Health Organization developed this multi-reference growth standard, and it came out in like 2005. And what they did is they did globally, they picked, I think, 6 to 8 countries. And they said, if kids were optimally breastfed and fed and given all the nutrients, and they were middle class and well nourished, how tall would they be optimally? And they picked, like, I think countries like, well, the US, China, a country in India, I think someplace in India, someplace in Indonesia, Africa, you know, different countries, but they had to be optimally fed. And then they took all those kids and then they averaged them, and they said, this is the optimal growth curve. But before you know what the growth curve was, United States, kids in Ohio. So now the growth curve is
I only point this out because we actually, my family has a letter from one of my ancestors in the 1880s. And the reason he and his unmarried sisters immigrated to the United States is because he was refused admittance to the Navy, the British Navy, because of extreme short stature. So I only point out that, you know, some of us were not meant to be gone.
Good point. Good point. Yes.
Fascinating talk. So I have some questions about the first intervention trial. So it looks like you enrolled the pregnant women somewhere in the first trimester, somewhere in the second trimester. So I wonder whether you looked at just the people involved in the first trimester, start intervention from the first trimester, whether that makes any difference. That's the first one. The second one is, when we evaluate air pushing's first weight, the pregnancy loss is always a concern. It's made by the result. I wonder if you look at air pushing's pregnancy loss, is there any difference between the two?
Yeah. Yep. Good. It's good. Good. Those are great. So in the first trial, Respire trial, we there were only 30 pregnancies out of 190 that were enrolled in the first trimester. So it's kind of too small to see any effect. In the second trial, there is a paper that looked at pregnancy losses. They looked at all fetal outcomes, miscarriages, well, by different, stillbirths, late term miscarriage, or spontaneous abortions, neonatal deaths. These maternal outcomes like postpartum hemorrhages. 2 different papers by Ashley Younger in the HAPIN trial, because that had enough 3,000 pregnancies to be able to look at it, and nothing was found statistically significant in those 2. But that's the largest trial of household air pollution to be able to look at those rare outcomes. But those papers were published. We went through everything because we had to report those severe adverse outcomes. So we had those. But the other thing is in HAPIN, we enrolled pregnant women between 9 and 19 weeks. So we didn't get they were mostly around 13 weeks. So we didn't get the first trimester in HAPIN. We didn't. So we didn't have a lot of early losses. Yeah, maybe we were like, we had to do a ultrasound confirmed pregnancy. Yeah, they didn't show up. Yeah.
So, active member of American Thoracic Society.
Oh, okay, great. Yay.
Related to pulmonary diseases above and beyond pneumonia that you mentioned, like for the kids, after 5 years follow-up, was there an asthma or?
We're now looking at lung growth. I'm on an R01 with John McCracken from University of Georgia, and we're looking at the lung growth in these kids in Guatemala. So we're doing forced I can never say that word, FOT, forced assimilarity. And we're doing pulmonary function and spirometry on the children to see their lung growth patterns. Yeah.
So the suspicion is related to the microplastic or
No, that would be for the HAPIN trial. It would be, did early life exposure difference in the gas stove trial affect their lung growth now that they're 5 to 7 years? So we're looking at that. And in the Respire trial, we also looked at lung growth in children as a result of the wood stove trial. Yeah. Particulate matter. Yeah. Yeah. Yes.
The mother and the father, like kind of the safety standards for manufacturing and the flowers out there too. The standards are so much lower.
Yeah. Well, in all of these places where the Respire and HAPIN trial, where they're agricultural, they're rural agricultural, the only thing I could say that they would be exposed to, because they're not really working industrially, is pesticides. There's a lot of pesticide exposure because they're subsistence farmers, and they basically live off of growing corn and coffee. And so they wear these backpacks where they spray pesticides. So that is an exposure I think that we haven't really looked into. We're asking women to wear these silicone wristbands, so we're going to measure pesticides and stuff on the wristbands, which I didn't mention, but they're not spraying the pesticides, the men are. But really, there's no other industrial exposure. There's a lot of diesel and car pollution, though, from road traffic. Yeah, definitely ag industry, yeah.
Wonderful discussion, but we are about the time for lunch. Thank you so much, Dr. Thompson, for the wonderful presentation.